And this is the point that I think we might want to kind of consider as we think about our guidelines now. This dichotomy between first and second generation antipsychotics is really not a useful one. It may have served us well in terms of simplifying our thinking about what we thought we knew. But if we look at all the data, this is not a useful dichotomy. Why? Because in terms of efficacy, you take clozapine out, they're about equally effective. No consistent differences in efficacy. There are differences in how easily you can dose different medications, etc. But having said that, in terms of efficacy, not any real differences other than clozapine. Two, within both classes, not between classes, but within both classes, there are varying degrees of risk of EPS amongst the so-called atypicals, risperidone, quetiapine. You know, in terms of EPS risk, they're hugely different, just as Mellaril or thioridazine and haloperidol are. And if you compare thioridazine to quetiapine in terms of EPS risk, yeah, quetiapine has a little lower EPS risk than thioridazine, but thioridazine has a lower EPS risk than does risperidone. And of course, there are variations in terms of the dose response. I'm simplifying stuff. But the bottom line is, in terms of EPS, there are differences within both classes. Similarly, metabolic side effects. We have this belief that atypicals cause more metabolic side effects than typicals. I mean, all of us believe that. Except that's not true. On average, that might be true, but there are differences within both metabolic classes. I mean, both antipsychotic classes. Aripiprazole, ziprasidone, cause as little weight gain or metabolic side effects as the best amongst the so-called typicals, molindone, for example. And clozapine, olanzapine, cause not a whole lot more metabolic side effects than, say, a Mellaril or a chlorpromazine thorazine. The bottom line here is there are significant differences in EPS and metabolic side effects and other side effects within each class. So this is not a useful dichotomy if you look at fact, if you look at the data. Okay? There are varying degrees of ease in terms of how you can dose within both classes. It's relatively easy to dose olanzapine, for example, which is why in clinical practice it was an agent that people liked using, despite metabolic side effects, whatever it is. And some guidelines like Port and the Florida guidelines suggest that, you know, at least in first episode patients, do not use olanzapine first. Despite those recommendations, it's widely used. Why? It's an easy agent to use. It's easy to dose. Quetiapine, more difficult to dose. Ziprasidone, more difficult to dose for different reasons. You have the same kinds of issues amongst typicals as well. So the first suggestion I would make as we think about our guidelines is really, let's get away from this dichotomy between so-called first and second generation antipsychotic agents, because it's not terribly useful and in fact misinforms. And so the issue really is this dichotomy is not useful, but there is something useful about this conception. And I think what's useful is this. It's not the agent. We try to simplify, okay, 10 agents of this and 10 agents of that. Rather than thinking of 10 agents of this and 10 agents of that, let's think about the 20 agents as varying in these different properties. And this is what we want. When we're treating patients with schizophrenia, we first want to get a very good antipsychotic effect as easily, as fast as possible, without Parkinsonian side effects. That's what we want. Because these benefits, you mentioned tardive dyskinesia. The risk of tardive dyskinesia is intimately linked to the risk of EPS, whether it's the agent you're looking at or whether it's the patient you're looking at. If a patient develops EPS in the first 6 months of antipsychotic treatment, that patient is 5 times more likely to develop tardive dyskinesia after 1 year or 5 years of use, depending on whether you're looking at elderly or whether you're looking at the younger patients, as a person who does not develop EPS in the first 6 months of use. So the bottom line here is, this is the critical issue. And this does not map easily onto typical atypical. It really involves an interaction between the agent, and there are differences amongst the agents which don't neatly divide into typical atypical. The patient vulnerability, different patients are vulnerable to different side effects, and that's an important consideration. Some more to EPS and hence TD than others. And how you use the particular agent. Just to close this out, and I'm going to skip the third part, one part of the presentation in the interest of time. I want to move straight to guidelines from this discussion. But just in terms of other classes of medications, in the treatment of schizophrenia, antidepressants do have a role. They have an important role in treating depressive symptoms, particularly depressive symptoms that persist after psychotic symptoms have improved. I did not mention anti-EPS agents. We often miss EPS, and we see some of the associated features of EPS, like dysphoria, for example. And there, treating the Parkinsonian side effects is important. Anticonvulsants have a very limited role. They're not particularly useful agents in augmentation. And lithium, you could add to these anticonvulsants as well. And they have a very limited role in treating agitation, although a significant proportion of persons with schizophrenia get anticonvulsants and/or lithium. Benzodiazepines do have a useful short-term role in treating agitation in patients who are acutely psychotic, but a very limited role in treating anxiety symptoms, although a few patients do benefit from benzodiazepines long-term, if you will. Other agents, no real established utility. So new developments since 2009, relatively few. We had iloperidone and asenapine available, some broadening of indications for them, certainly more data about them. Lurasidone was introduced, and lurasidone is an ON, if you will. Risperidone, ziprasidone, paliperidone, it's an ON. In contrast to the ENs, which are quetiapine, clozapine, asenapine, if you will. Iloperidone is an ON. Now, all the ONs like to say we're the best ON in that we don't cause much, we are better than the ENs, all the ONs are, because we cause fewer metabolic side effects. But we're better than the other ONs as well because we don't cause as much EPS. I mean, that's the basic, that's the kind of distinction they try to make. All the ENs, on the other hand, try to say, we're certainly better than all the ONs because we're much less likely to cause EPS. And we're better than the other ENs because we don't cause as many metabolic side effects. I mean, that's been the stance, if you will, if you look at the message about lurasidone or asenapine or iloperidone, the three new agents that have been introduced. The bottom line is, if you look at lurasidone, it does cause a little more EPS than the ENs, if you will. Meaningfully more, a little more. You can have questions about that. The data suggests that it is an ON, and metabolically, it's a pretty good agent. It does not cause as much weight gain as the ENs, certainly, and perhaps a little less than risperidone, perhaps, maybe a little more than ziprasidone, perhaps. I mean, we don't have the hard data to kind of really define exactly where it fits. Asenapine and iloperidone have both been promoted extensively in the last couple of years. They were available the last time we reviewed it, but they have been promoted. Not used a whole lot, but they are available and they have been promoted. So what do we do? So there are things we can do, and we probably need to do more of. So just in terms of development, the other thing that's happening is, a glycine T1. This is a glycine transporter inhibitor. Basically, there have been trials of this medication, and it remains to be seen if it's useful for the treatment of negative symptoms or not. There is another medication, caripiprazine, which essentially is being evaluated and may become available within the next couple of years. Not very likely. It has some interesting attributes. It's got dopamine 1 agonist properties, some dopamine 1 agonist attributes, and it's got some partial agonist attributes as well. And so it remains to be seen, a D2 partial agonist attribute. So it remains to be seen where that goes. I'm going to skip this part of the presentation, but this is where the field over the next 10, 15 years might be going. New molecular targets, there's a whole range of them, which are being looked at, about 150 agents, and you've got that in one of the papers that you have, listing all the agents that are being field tried and what stage they're at. Rational polypharmacy, targeting different domains with different agents, is something to be looked at. This is a cute slide, so I'll show this to you. That in terms of targeting different stages of treatment, there are many opportunities for intervening in schizophrenia. So in contrast to normal development, in the decline that you see in schizophrenia happens at multiple points. The bottom line being that essentially we have an opportunity to intervene here, 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 and go ongoing. And this is where RAISE is at, if you will. And this is where the attenuated psychosis syndrome effort is at. So what do we do? So this is the reality of schizophrenia. We've got treatments. They are effective. They're not fully effective. And despite treatment, patients don't do very, very well. Less than 15%, 20% are employed, fully employed, fully independent. And they keep having these symptoms despite they're not doing very well. So how do I decide which antipsychotic is best? Well, it depends on the agent, it depends on the patient, and it depends on how you use that agent, which has to do with issues of dosing. And this is what we do know. Efficacy is about the same except for clozapine in refractory patients. Patients vary in response. There's no great predictor yet that we have about who's going to respond best to what medication. Agents differ. They're not the same. And they don't even neatly divvy up into typicals, atypicals. There are 20 different agents, and they're all different. Patients are different. Different agents have different side effects. Different patients have different vulnerabilities and preferences. There's no good predictor of how to match them. And we know switching is risky. This was brought up by Dr. Newcomer yesterday when Dr. Constantine presented the study. Switching is risky, no matter what. So one of us, clinicians are way ahead of the researchers. We don't switch, we add. I mean, we don't stop the old agent, we add. I mean, because we know switching is risky. We know stopping the old medication is risky. So the point is switching is risky, which is why trying to get the first agent as right as possible is important. And that really speaks to Dr. Ketter's point, which is, so we keep trying different agents? But there are things we can do, and this is the best we can do. And in terms of using the medication as best as we can, there are three things. And this is something we're going to talk about, sequence, when we talk about guidelines. It has to do with how you sequence different medications, how you dose different medications, and how long you use these different medications for. And in terms of sequence, a systematic 6 to 10 week trial of one antipsychotic with optimal dosing is probably the first thing to start off with. And then we'll talk about what the issues in dosing are. Then if that doesn't work, try another agent. If that doesn't work, think about clozapine. And if non-adherence is a significant factor or consideration, think of a long-acting agent. And you'll see this is what's reflected in our guidelines in terms of this particular sequence, if you will. Only then, only after we've tried the more proven or the more evidence-based treatments, do we get to strategies that are more desperate, but maybe warranted because we want patients to get better, but don't get to these strategies before you've tried these. And no matter what you do, measure. In terms of dosing, these are the 5 considerations. What's the initial target dose I go to? And we make mistakes, considered mistakes, but we make them both underdosing and overdosing in terms of initial target dose. If a little is good, let's try more. Let's start them on 40 milligrams of olanzapine per day. Or let's start them on 8 milligrams. Let that be the target dose. Or, tolerability is such an issue, let's give them just 1 milligram of aripiprazole for 4 weeks. I mean, so I'm exaggerating, but we've made mistakes. So we really need to think through what the initial target dose should be, how best we can get up there as rapidly as possible, as safely as possible in terms of tolerability. That's important. How long should we wait at this initial target dose? Generally about 3 weeks or so, 3 to 4 weeks. Wait once you've set this. What's the highest dose of this medication that's likely to be useful? Knowing there's variation across individuals, what's the dose beyond which if we go, it really is a likely exercise in futility? And how long do I give this medication before I go to another medication? These are some of the things that we need to consider. And very important, measurement-based care. That's why we need to measure, because we can't predict before going into it how the patient's going to respond. Let's measure how the patient is responding and react to that effectively.